Thank you very much indeed, and I'm absolutely delighted to be here. And I'm particularly delighted because, as I think you know, I've been involved in the funding of research and innovation really for a rather long time now. And it's always struck me as sort of slightly paradoxical, though easily explicable, that people put an enormous amount of effort into writing applications for funding. The applications go in, hopefully, with every I dotted, every T crossed, and hopefully some interesting questions to be answered. But people forget that the effort they put into funding, what we're really interested in as funders, is what's been done with the money, what's been discovered, what have been the outputs and the impacts of the work. And sadly, historically, that's been much harder information to collect because people put much less effort into reporting at the end than they do in applying for the money at the beginning. And so it's a particular pleasure to come to an event like this where one actually hears what's happened to, in this case, money confiscated from all of us as taxpayers. And so I think there is something wrong in the funding model because we do naturally need, what really matters is what happens to the money. So it was just a pandemic ago that I had the privilege of speaking at the launch event for the Digital Innovation Hubs, which was in London a few years ago. And although the initial tranche of funding is coming near the end, I'm delighted that a number of the hubs have developed sustainable funding as a result of the success of the work, and I hope that more will. And I hope very much that the hub programme will continue and evolve. And of course, we've just heard from 2 new hubs which have arisen from new sources of money. Although it was a pleasure to hear about MQ, which of course was founded by the Wellcome Trust in about 2011 or 12. I thought I would just spend a minute or two exploring the origin of the Digital Innovation Hub programme because it is actually quite interesting. So their immediate origin was a funding competition which was led by HDR UK in May 2019. And that was supported by an initial £37.5 million of investment from UK Research and Innovation as part of something called the Industrial Strategy Challenge Fund. And indeed, this was a new type of funding from what was then still a very young organisation. UKRI itself can trace its genealogy back to the Government Science and Innovation Strategy that was published in 2014, which was called Our Plan for Growth, Science and Innovation. And the signatories in the foreword for that report were George Osborne, then the Chancellor, Vince Cable, remember him, and Greg Clark, who at the time was Minister of State at that time for Universities, Science and Cities. And it's quite interesting the way ministerial portfolios move around over time. But of course, one of the most consequential elements of that paper was that Paul Nurse was asked to lead a review of the research councils. And that led to the formation of UKRI, which was established on the 1st of April 2018 by the Higher Education and Research Act of the year before, 2017. And the funding for UKRI came from 2 sources. So the first comprised the aggregated funds largely for discovery research from the research councils. It came from the innovation funding of Innovate UK, and then the dual support funds for universities, for English universities, from Research England. Although, of course, UK Research and Innovation is active across the UK. It's in the name. But the second source was important new funding that originated in the autumn statement of 2016. And in that statement, the Chancellor announced the creation of something called the National Productivity Investment Fund, the acronym NPIF. And that was £23 billion to support areas that were deemed to be key to boosting productivity. And research and innovation was a key component of these, alongside transport, digital communications, and indeed housing. And a significant part of the research and innovation funding from NPIF ended up in UKRI, which has amounted to nearly £5 billion between 2018 and 2022. The Industrial Strategy of November 2017, which was led again by Greg Clark, who by now was Secretary of State for Business, Energy and Industrial Strategy, laid out 4 grand challenges. And they were the future of mobility, clean growth, artificial intelligence and data, and ageing society. And these grand challenge areas, not surprisingly really, formed important determinants of how UKRI was able to spend the NPIF funding. And I have to say that the Treasury retained tight oversight of how the funds were committed and spent, in addition to the oversight of BEIS, which did add additional layers of oversight and delay to the programmes that were quite frustrating to all concerned and were later criticised by the National Audit Office and the Public Accounts Committee. But that's another talk altogether, and I'm not going to give it now. But it was agreed that UKRI would form an Industrial Strategy Challenge Fund to support research and innovation in these 4 areas. And the area of health was encompassed in the ageing society strand of the grand challenges. And although the Industrial Strategy Challenge Fund initially took up the lion's share of the NPIF funding, and it was over £500 million in the initial 3 waves of the Industrial Strategy Challenge Fund, there were a number of other new strands of funding for UKRI that came from NPIF, including about £192 million for a Strategic Priorities Fund, and it was from this, in fact, that the MRC funded the Alleviate Digital Innovation Hub that we've just heard about in partnership with Versus Arthritis. There was also £100 million for Future Leaders Fellowships, nearly £70 million for a Strength in Places Fund, and various other monies as well. But an important feature of the Industrial Strategy Challenge Fund, and I used to say at the time, it's in the name, it needs to have a relationship to industry, it was about economic growth, and it needed to cover strategic areas. So an important feature for that was the essential need for industrial partnership and funding alongside public funding. The fund was set up essentially to build on research and innovation excellence in areas that were important or thought to be important for the future economy of the UK to grow businesses and improve productivity. And that was the origin of the digital innovation hubs, which were part of an extensive series of health innovation programs. And it's worth remembering that the VMIC, the Vaccines Manufacturing Centre, was in fact a component of the Industrial Strategy Challenge Fund, and ironic that it was still mired in planning issues around Oxfordshire at a time when the pandemic struck. And so it did contribute to the vaccines development, but largely not through the physical infrastructure, but through the equipment that was bought and used in other places. So I want to wind forward to the present because the NHS is at a critical juncture in its history. Following the COVID-19 pandemic, I think everyone would agree that it's probably working under the greatest pressure since its foundation in July 1948. And even before the pandemic, it was facing a relentless increase in demand resulting from the demographic consequences of an aging population and changes in the NHS workforce. And, of course, the world of health, treatment of disease, has gone through an extraordinary revolution. So extraordinary new diagnostic and technological advances have increased both the range and also the intensity of possible clinical interventions. And the truth is that as a result of a combination of public health measures and modern therapies, populations around the world are living longer and healthier lives than any previous generations. But the thing that we have not succeeded in doing is compressing late life morbidity. So the upshot is that we live longer, but we are ill for longer. And the consequence is unsustainably rising healthcare costs. All of this has been amplified by the consequences of the COVID-19 pandemic, which, again, I think we can all agree, has illustrated rather starkly the social determinants of ill health, and indeed significant imbalances in health and social care provision across the country, and indeed across the world. COVID-19 has left in its wake, and of course we haven't left COVID-19 behind, a huge backlog of delayed diagnoses and unmet medical need, including a greatly increased burden of mental distress and ill health. But in spite of all this, the NHS is an extraordinarily powerful and successful model for the provision of healthcare, available to all and free at the point of delivery. And the NHS rose magnificently to the challenge of providing care under the most difficult circumstances throughout the pandemic. And working with government and industry, There's no question it created and delivered an outstandingly successful national programme of vaccination. Indeed, it worked at pace with academia and industry to conduct a world-leading programme of research and innovation in the heat of a national and indeed a global emergency. And as you've heard today, nationally collected data sets from the NHS were used on a daily basis, both to manage healthcare delivery and also to provide the information to scientific advisors and policymakers that was essential to assist them in making difficult policy decisions throughout the pandemic. And I saw this because I remained a member of SAGE, and of course I was running UKRI, at least at the start of the pandemic. And as we've heard, and I won't repeat everything that's been said, several of the HDR UK digital innovation hubs pivoted their work rapidly to support the national and global effort to understand and manage the COVID-19 pandemic, and played a key role in facilitating and leading the national and global efforts. So a few examples are the work of the NHS Digitrials platform, which was initially led by Sir Martin Landry and his colleagues, who delivered the recovery trial, which just showed the extraordinary power of the NHS to deliver clinical trials through the participation of many district NHS hospitals, which recruited an enormous number of patients in the context of huge pressures on care teams and faced with overwhelming numbers of extremely sick patients. And we've now heard about NHS Digitrials, which I think has the potential to transform how clinical trials are done across the UK. And we've also heard from Aziz Sheikh, now Sir Aziz Sheikh, congratulations, his work in Scotland with his team on the Breathe Hub, which pivoted and delivered the EVE2 study. And it was just extraordinary to see how, in real time, it showed the effectiveness of vaccines in a population the size of Scotland. And the hubs also worked very effectively at a local and regional level. So in Birmingham, the Pioneer Hub provided powerful data for University Hospital Birmingham Foundation Trust. And I should say, and I'll come back to this point, that it was building on sustained work at the Queen Elizabeth Hospital in Birmingham on using data to improve the care and outcomes of acutely sick hospital admissions. And years ago, I visited the hospital when Julie Moore was the chief executive and was extremely impressed as you went from ward to ward by the dashboards that were there, collecting prescription data in real time, and they basically largely eliminated prescription errors from that hospital. But my frustration is that all too often initiatives like these don't scale. And in this day and age, it's scandalous in a way that we don't use health data to ensure that prescription errors become a thing essentially of the past. In London, the Discover Now Hub pivoted to support the vaccine programme in northwest London. So the hubs did their bit in terms of both national and local research and innovation and delivery. But I think that the opportunity now, looking to the present and the future, is to transform the NHS and to capitalise on that agility and innovation shown by the NHS during a time of crisis. And frankly, one of the key planks of this transformation is joining things together better. It's about integration of services between primary and secondary care, between health and social care, and between the maintenance of health and the management of disease. And I don't think there's anyone in this room who would disagree that the effective use of data will be absolutely essential to transform the NHS, ranging right across improving the logistics of healthcare access and delivery. If I could fix one thing, it would be to improve the logistics of delivery of the healthcare system. In fact, Bill Gates, many years ago, said that every service industry in the world has been transformed by the use of data, except for healthcare. And sadly, that still remains the case. Just the journey of people through the system could be facilitated by much more effective use of data. And logistics may not feel like an intellectually exciting subject, but I can tell you that it is. It offers extraordinary possibilities. So, and we also obviously use data effectively to deliver both prevention and care to individuals, to their families, and to communities. And so it is essential that we learn lessons from what has worked and what has not, and what can we learn from the digital innovation hubs. One important lesson is that success is often built on success. So how do we capitalize, build on, and grow on previous successes? And there are some obvious examples in the sphere of the digital innovation hubs. So turning to the bioresource, the Cambridge Bioresource, which started as a community of local healthy volunteers, which was constructed initially by John Todd and his colleagues, was initially created to understand the links between genetic variation and susceptibility to diabetes. And this has grown under the stewardship of NIHR into a national network. And of course, it was the bioresource that has provided the successful underpinning for gut reaction, which you heard about earlier. I would argue that two of the most important lessons from COVID itself are firstly, to be prepared, and secondly, neglect public health at your peril. So in the case of be prepared, our success in the vaccine program dates back to investments over very many years in immunological research, in vaccine science, and of course, the reason that Oxford and Sarah Gilbert and her team were in a position to develop a COVID-19 vaccine was because they'd been funded to develop a vaccine for the coronavirus MERS, dating back to 2015. And so they were primed and ready to go. In the case of the epidemiology and study of severe infectious diseases, there was an established partnership with the acronym ISARIC, International Severe Acute Respiratory Infection Consortium. That was created in 2008, and it came out of the work of Jeremy Farrar and others in Vietnam on emerging infectious diseases. And indeed, I think you can see that countries that had been exposed to severe or epidemic infection were those that were most prepared. And so Korea, which had had a very nasty outbreak of MERS, had created an epidemic intelligence service. But ISARIC had protocols ready and waiting. And then another example is long-standing investment in infectious disease modelling at places like Imperial College and the London School of Hygiene and Tropical Medicine. And as I've already mentioned, in the conduct of the large-scale clinical trials in cardiovascular disease in Oxford that underpinned the formation originally of the DigiTrials platform. And as for public health itself, if we're to tackle the extremely well-known social determinants of disease, then we need granular data on health, on occupational, on social, on educational data, coupled with detailed geographical and environmental data. And there is another lesson, which is that life is not about a competition between the virtues of bottom-up funding of researchers with interesting, important, and original ideas for discovery and its application, versus the top-down funding of large collaborative multi-centre initiatives, such as the hubs that we're talking about today. There's another important lesson, which I think, again, people here will be sympathetic to, which is the need for patience. The UK Biobank was conceived 20 years ago. It successfully recruited 500,000 participants, of whom I and my wife are two, between 2006 and 2010. And it's because of the length and the richness of the data that it's been able to collect that it's really only over the last few years that it's begun to deliver important discoveries on a regular and escalating basis. And indeed, as part of the Industrial Strategy Challenge Fund, Biobank raised £200 million of funding from a partnership of public, charitable and industrial organisations to undertake the full genome sequencing of all 500,000 participants. That's just £400 per genome to include all the bioinformatic analysis that will turn those genome sequences into valuable information. And Biobank has in turn spawned another major initiative from the Industrial Strategy Challenge Fund, Our Future Health, a cohort of 5 million people that will link data describing clinical phenotype, diagnostic tests, and genetic analysis, which has the potential to transform the prevention, detection, and treatment of many chronic conditions. So future generations can hopefully live in good health for longer. And again, £79 million from UKRI has already attracted an additional £140 million of investment announced this year from a group of 14 major companies. So whilst not all of the digital innovation hubs have successfully created industrial partnerships, and in doing so leveraged industrial funding, overall the programme has been very successful. The public funding for 9 hubs of £27.9 million has attracted £43 million of leveraged funding. If I had one niggle, it is that I would have liked to have seen more scaling of activities across and between the different hubs. And whilst it's certainly true that collaboration comes at a cost, history shows that working at scale usually brings enormous benefits. And I'm afraid one of the challenges of innovation in the NHS is that all too often it fails to scale across the NHS as a whole. And my final beef is about the necessity that we take a much more integrated view of how we use health data. And in my view, there is actually one essential purpose that needs to drive the more effective integration and use of health data, which is quite simply to improve the health of us as individuals and the population as a whole. It's about prevention of disease and treatment if we're unfortunate enough to become ill. Now, as I've said, is the moment for integration between primary, secondary and tertiary care data, for integration between health and social care, for integration between the treatment of disease and the maintenance of health. And that's where the public health approaches for the 21st century will develop. And there are essentially 3 uses of data to achieve what's needed. Firstly, we need to use data to deliver what I call retail healthcare. In other words, healthcare to us as individuals, to our family members. And for that, you need completely personalized data. Secondly, we need to enhance public health at the level of the community, in our workplaces, in schools. The second broad use of data is for the purposes of health system management, for audit, for the logistic delivery of services. And the third use is for research and innovation in academia and industry, to discover new things about health and disease, to conduct clinical trials, to assess new therapies, new devices, and new digital approaches. But the underpinning data to achieve all 3 of these aims is essentially common to all of them. And I think that in the context of HDR UK, and indeed health research and innovation broadly, there's been an enormous amount of talk about trusted research environments. But I think what we really need is actually trusted health data environments with governance that is adaptable to handle the personal data in proportionate and sensitive ways. But at the end of the day, the core use of data is to make us better. And I think one of the challenges is that if we have our trusted research areas outside the NHS firewall, then how do you bring inside the firewall the application? You know, if you develop an algorithm outside it, frankly, its use is inside the firewall. And so I think that we need to have a very clear vision of what we're using data for. And ultimately, it's about making us all healthier and hopefully happier at the same time. And I think with all of the talk of levelling up, the challenge for the NHS is to level up at every scale, from the local scale, where there are huge disparities of health between the haves and the have-nots, in London, in Birmingham, in everywhere, in the country, in the cities. There is inequality, and you can see it. I looked from time to time during coronavirus at where the deaths were. And in southwest London, where I live, you could see that the mortality was in the poorer parts of the borough. So levelling up from local to national within individual integrated health systems across the country between different healthcare providers, we'll only achieve this if we use data properly. And of course, the purpose of technology is to help people. So the real transformation needed is in the workforce of the future, for whom the effective use of data will be the essential and the accepted tool to enable everyone working in healthcare to provide both human and humane care and the best public health. So congratulations on all your work. There's a lot to do in the future. Collaborate more. Thanks for your attention.